Hi everyone, I'm Dr. Irajan Khandelwal and now let us start with the next module from systemic pathology students, that is gastrointestinal tract. It is a very important topic for all MCQ exams, and if you're a second year student, a lot of long questions and short notes are asked from this topic, right? Broadly speaking, students, I have divided this big chapter into 5 different modules. Here in this module, we are going to study about the lesions of the esophagus. Then will come the lesions of the stomach. After that, I will do the lesions of the intestine, like the malabsorption syndromes and the various ulcers. Then we will do the inflammatory bowel disease, which include Crohn's and ulcerative. And lastly, we will do polyps and cancer, colon cancer. Correct? So 5 different modules for GIT. So the GIT which I teach in pathology has a lot of things in common with the GIT which you do in surgery, right? So what you have to do whenever you do a GIT from surgery, also do it from pathology so that you get an integrated overview of whatever we are going to teach you. Correct? Easy story, students. So shall we start our journey of gastrointestinal tract? Okay, so first of all, students, what is the normal histology of the gastrointestinal tract? You all know that the entire GIT is lined by 4 layers, students. What are the layers? Mucosa. Then we have the submucosa, the muscularis propria, and lastly, there is adventitia. So mucosa, submucosa, muscularis propria and adventitia. The mucosa is further divided into the epithelium, the lamina propria and the muscularis layer. Right? Understood? Easy story, students. Let me show you an image of the various layers of the gastrointestinal tract. This layer is the mucosa, in which you can see this epithelium, right? Then we have the submucosa. Here you can see this is the submucosa. And then below this we have a muscularis mucosa layer, students, in which there is an inner circular layer and outer longitudinal layer. Below this is the adventitia or the serosa, right? 2 exceptions to these 4 layers are the gallbladder does not have a submucosa. So no submucosa in the gallbladder and no serosa in the esophagus. The esophagus does not have a serosa, right? These are also very important points which you need to know. No serosa in the esophagus and no submucosa in the gallbladder. Correct? Easy? The basic thing is clear. Now let us move to the lesions of the esophagus. Now in esophagus, students, I'll just do 2 lesions with all of you. One is Barrett's esophagus and other is the tumors of the esophagus. There are a lot of other lesions like achalasia cardia or Zenker's diverticulum or Mallory-Weiss tear and all. But I'm not going to discuss them because they are actually clinical, totally surgical aspects. There is no pathology or microscopy which you need to know about those lesions, right? That is why the 2 lesions which we are going to discuss. First one of them is the Barrett's esophagus. This is one of the examiner's favorite topics, students, and I have covered most of it in the module on cell injury, right? Tell me, what kind of a cell adaptation is Barrett's esophagus? The first point. It is a kind of metaplasia. Now, if I ask you, what is the definition of metaplasia? Let us quickly revise. Metaplasia is a reversible change in which one differentiated cell type is converted into another. Remember I told you? So, what is the cell type converted in Barrett's esophagus? You all know that the normal esophagus has got a stratified squamous epithelium. This is the normal esophagus and the normal lining is a stratified squamous epithelium, correct? What happens in Barrett's esophagus, students? This stratified squamous epithelium gets converted into columnar epithelium, right? And why does it happen? Because of a lot of risk factors like gastroesophageal reflux disease. Suppose my patient has a lot of reflux from the stomach. So it will keep on irritating the esophageal mucosa, and ultimately can lead to Barrett's esophagus. So the epithelium from stratified squamous will convert into columnar epithelium. That is why this is called as a metaplasia, right? Now, broadly in clinical terms, students, if I tell you, this Barrett's esophagus is of two types. One is called as a short segment Barrett's esophagus. Another is called as a long segment. When do I call it as a short segment? When the metaplasia involves less than 3 cm of the esophagus, and when it involves more than 3 cm, we call it as a long segment Barrett's esophagus, right? Because the ultimate epithelium which is produced in Barrett's is columnar, that is why Barrett's esophagus is commonly called as columnar lined esophagus. Understood? We will call it as columnar lined esophagus or CLO. Columnar lined esophagus or CLO, right? So we have a short segment CLO and a long segment CLO. Now, if I ask you students, what is the important microscopy of Barrett's? Very, very important. The slide will show what? Columnar epithelium, right? What is the characteristic of columnar epithelium, students? The characteristic of intestinal columnar epithelium is the presence of goblet cells. That is why the hallmark of Barrett's esophagus on microscopy is the goblet cells, right? So two things which are important here. One is this called as intestinal metaplasia. Why? Because it shows the presence of intestine-like epithelium. Intestinal metaplasia. And the second one is the presence of goblet cells. Now, you people tell me, what does the goblet cell contain? These goblet cells contain a lot of mucin, right? And what is the special stain which we use for mucin, students? The special stain which we use for mucin is Alchin blue. That is why if they ask you what is the special stain for Barrett's esophagus, the answer is Alchin blue. All the questions are clear, right? So because it produces a lot of mucin, that is why the special stain which we can use for Barrett's esophagus is Alchin blue, which is actually a stain for mucin. It is not present in a normal stratified squamous epithelium but present in Barrett's esophagus because it shows the presence of goblet cells. This special stain question was asked in the NEET exam 2 years back. So what are the important points we have done for Barrett's till now? It is a kind of metaplasia from stratified squamous epithelium to columnar. What is the risk factor? Gastroesophageal reflux disease. What is the microscopic appearance? Intestinal metaplasia and goblet cells. Because goblet cells contain mucin and the stain for mucin is Alchin blue, that is why the stain for Barrett's esophagus is Alchin blue. Simple. Let us see a few images so that we better understand it. Okay, this image, students, shows this velvety thickening. Can you people see this reddish area which is there on endoscopy? This reddish part is actually Barrett's esophagus, and this is actually normal esophageal mucosa. So on endoscopy, it shows a red velvety appearance, right? Can you people appreciate the difference? This is Barrett's, and this pale mucosa is the normal esophageal mucosa, which is stratified squamous epithelium. Correct? Then students, this is another biopsy which is taken. Can you see this reddish areas? This is all Barrett's. Then microscopy is extremely important. Can you people appreciate this epithelium? Now in pathology, what is this kind of epithelium? This is stratified squamous epithelium. Now you people are experts, right? So this is stratified squamous epithelium. Suddenly on the biopsy, I see that this epithelium has changed and I see something like this. What is this? This is actually columnar epithelium. And can you people appreciate these empty looking cells which are there? These empty looking cells, right? What are these cells, students? These all are goblet cells. And what do the goblet cells contain? Goblet cells contain a lot of mucin. In a normal esophageal biopsy, what you should see is just stratified squamous epithelium. But when there is a biopsy and you see both of these epithelium, the answer is Barrett's esophagus, right? In AIMS exam 4 years back, there was a question, a 42-year-old female with gastroesophageal reflux disease presented with some dysphagia. Then the esophageal biopsy is given below. What is the most likely diagnosis? The biopsy shows this kind of a appearance, right? Another appearance to explain you the same thing, students. This epithelium which I see here, this is actually the stratified squamous epithelium, and suddenly I see that a lot of these glands are formed with the presence of these cells. What are these cells, students? These are actually goblet cells, right? So this is Barrett's esophagus for you, right? Now see this image, students. What do we see in this image? This shows the Alcian blue positivity of the columnar epithelium in Barrett's esophagus, right? Can you see beautifully these all goblet cells? They are Alcian blue positive. So Alcian blue positivity in Barrett's esophagus. This image can now be given in your MCQ exams because the examiner has exhausted himself with all the other questions regarding the stains or the kind of metaplasia or the normal image of the Barrett's esophagus. Now this image can come. Correct? Easy? Okay. So my next question is, Barrett's esophagus leads to increased risk of which cancer, which malignancy? The answer to that is adenocarcinoma of esophagus, right? So that is another question. It leads to increased risk of adenocarcinoma of esophagus. Understood? Very important point, students. Of course, students, see what is happening in Barrett's esophagus. There is a formation of glands and intestinal type of epithelium. If glands are formed, which cancer will it lead to? Adenocarcinoma, right? So whenever we have a patient of Barrett's esophagus, we have to keep following up of the patient, doing repeated biopsies, because you have to see that whether there is any dysplasia which is occurring in this Barrett's esophagus, because that particular dysplasia can lead to adenocarcinoma of esophagus. Easy story? With this, I finish off everything about Barrett's esophagus. Let's move to the next entity, students, that is the tumors of the esophagus. If I ask you a question, which is the most common benign tumor of esophagus? Benign tumor of esophagus, the answer is going to be a leiomyoma. What is the origin of a leiomyoma? It means it is a smooth muscle tumor, benign tumor of smooth muscle, right? Understood? Esophagus has got smooth muscle, so this tumor arises from that. Now, students, wherever in the body there is a leiomyoma, you have to remember two important things. One thing that you have to remember is that microscopically it shows the presence of spindle-shaped cells with cigar-shaped nuclei. Spindle-shaped cells with cigar-shaped nuclei. Very important. Cigar-shaped. Why? Because this looks like this, cigar. That is why it is called a cigar-shaped nuclei. And the second thing which you need to know is what is the marker which you will do. For any smooth muscle tumor, did I tell you what is the marker? The marker is smooth muscle actin, right? So the marker which we can use is SMA. That is smooth muscle actin. Correct? Easy story? So spindle-shaped cells with cigar-shaped nuclei and smooth muscle actin is the marker. Leiomyoma anywhere, whether it is uterine leiomyoma or it is in the esophagus. Let me show you a picture, students, because that is also very easy. In this picture, can you people appreciate these cells? Now they have got pointed ends. These cells are called as the spindle-shaped cells, right? And if you see these nuclei, they are like this. They look like the shape of a cigar. So these are called as cigar-shaped nuclei. Can you see any atypia, necrosis, mitosis, pleomorphism? No. That is why this is a benign tumor, leiomyoma. What is the malignant counterpart called as? Leiomyosarcoma. What will be the additional marker for a sarcoma? Vimentin. Understood? Done? Okay. Let's now move to the carcinoma of esophagus. esophageal carcinoma. Now, esophageal carcinoma are broadly of two types, students: squamous cell carcinoma or adenocarcinoma. We have a squamous cell carcinoma or adenocarcinoma, right? What is the location of squamous cell carcinoma? It is usually the middle 1/3 of esophagus, usually present in the middle third of esophagus, and adenocarcinoma is usually present in the lower 1/3 of esophagus, right? When there is gastroesophageal reflux disease, it will go up, right? Can lead to Barrett's esophagus, usually in the lower 1/3. That is why adenocarcinoma is also common in the lower 1/3 of esophagus. Simple story, students. Let us now study the risk factors for both of them, right? This is squamous cell carcinoma, adenocarcinoma. What are the risk factors? Very important, students. For SCC, smoking, alcohol, two very important risk factors, students. Foods rich in preservatives. These days we are consuming a lot of these packaged foods which are rich in preservatives. That is why the incidence of gastric esophageal cancer is increasing, right? Smoked food, Tylosis palmaris, achalasia cardia, vitamin E and selenium deficiency, Zenker's diverticulum, corrosive injury, and Plummer-Vinson syndrome. These are the important risk factors for esophageal cancer. Which type? Squamous cell carcinoma. And what are the risk factors for adenocarcinoma? Smoking, alcohol are common. Then very important risk factor is gastroesophageal reflux disease or Crest syndrome or Barrett's esophagus. These three are very important, correct? And in adenocarcinoma, P53 and RB mutations can also be present. Understood, students? Easy story? Okay. The overall most common cancer is the squamous cell cancer, and the most common esophageal cancer in the Western world, the answer is going to be adenocarcinoma. The location we have already discussed, right? Then comes my point, students, that is microscopy. What do you see on the microscopy of a patient with SCC anywhere in the body? Did I tell you? SCC anywhere in the body shows the presence of keratin pearls and desmosomes. In this picture, can you beautifully appreciate these pink islands? What are these pink islands, students? These are keratin pearls. I will keep on repeating this in female genital tract or lung or oral cavity or esophagus. Wherever there is squamous cell carcinoma, it will show the presence of keratin pearls. These pink colored pearly things. Some students ask me, ma'am, this looks like a Samoma body. No, this is not a Samoma body because Samoma body is a calcification. So that is basophilic or blue in color, right? This is keratin, which is pink in color. Can you people see? This is more pinkish. And there are no nuclei. There can be a nuclei in this, but not in Samoma body. Correct, easy? Another thing which I see on high power is the presence of desmosomes. If I ask you what is the marker which you will apply for a poorly differentiated SCC, if you don't know, the answer is cytokeratin, or I can use P63. Cytokeratin or P63 is a marker which I can apply. Easy? When a patient has got adenocarcinoma, I've told you many times, we see glands which are lined by pleomorphic cells. In this lesion, can you appreciate these glands? So what I see are these glands which are lined by pleomorphic cells. Pleomorphic cells. Adenocarcinoma anywhere in the body, right? Now, the next question is, what is the most important prognostic factor for esophageal cancer? Students, this is not a very good cancer. I have seen patients dying quite quickly if a patient has esophageal cancer. Not a good cancer, but what determines the prognosis in most of the GI malignancies is the depth of invasion. Where is the tumor exactly penetrating? The tumor in mucosa and submucosa is better as compared to tumor which is penetrating all the layers, right? What are the layers? Mucosa, submucosa, muscularis propria adventitia. So the deeper the lesion, the poorer is the prognosis. In fact, the staging of most GI malignancies is also based upon this depth of invasion, right? So if the examiner asks you most important prognostic factor, answer is depth of invasion. How is a patient going to clinically present? Patient can have dysphagia, which is more to solids than to liquids, right? Weight loss, anorexia, these are other symptoms which can be present. And lastly, the barium scan, if you do, it shows a characteristic rat tail appearance. Can you people appreciate this? Don't you think it looks like the tail of a rat? You all know that radiologists and pathologists, we both keep on imagining things and observing things, right? So that is why this appearance is called as the rat tail appearance. Correct? That is seen in the barium swallow of a patient with esophageal malignancy. Easy story, students. With this, I finish off with the lesions of the esophagus. Let us solve a few MCQs. A patient with recurrent gastritis has been diagnosed with Helicobacter pylori infection. Which of the following is true in this patient? Now, the patient has recurrent gastritis and H. pylori. Increased risk of adenocarcinoma of esophagus, decreased risk of adenocarcinoma of esophagus, increased risk of SCC esophagus, decreased risk of SCC esophagus. Students, why I have picked up this question? Because I want to tell you one important thing, that H. pylori has been known to be protective against adenocarcinoma of esophagus. So basically the answer has to be decreased risk of adenocarcinoma of esophagus. So here in this table, you can actually write down that H. pylori is protective against adenocarcinoma of esophagus. The new studies are showing that. That's why I've given you this question. Correct? Next. A 58-year-old man has had increasing difficulty swallowing for the past 6 months and lost 5 kgs weight. No abnormal physical findings are noted. Upper GI endoscopy reveals a nearly circumferential mass with overlying ulceration in the mid-esophageal region. Now, two important things. A mass and an ulceration in the mid-esophagus. What does it usually signify? It usually signifies SCC of esophagus, which occurs in the middle 1/3. Biopsy of the mass reveals pink polygonal cells with marked hyperchromatism and pleomorphism. Which of the following is the most likely risk factor for the development of this disease, right? So you have to tell us that which is the risk factor for SCC. Iron deficiency, no. H. pylori infection, no. Chronic alcohol abuse, yes. I told you smoking and alcohol are very important risk factors. High fruit diet, no. Fruits are always good. So high fruit diet has to be good, does not lead to any cancer. Zenker's diverticulum, no. Right? So the best answer here is chronic alcohol abuse. Zenker's diverticulum can also lead to increased risk, but not that much as compared to chronic alcohol abuse, which is a better answer. Clear? Easy story? Last, students, we were reading about one syndrome here. Let us quickly revise that. Plummer-Vinson syndrome, because you can get questions on that also. Plummer-Vinson syndrome is usually seen in middle-aged females, and this syndrome is characterized by a triad of esophageal webs, atrophic glossitis, and iron deficiency anemia. These are the three things which can be seen. So in the MCQ exam, you can be given a clinico-pathologic history, like a 32-year-old female presented with, iron deficiency anemia, and the patient also has some glossitis. What is the other thing which the patient can have, or which syndrome is the patient most likely suffering from? The answer is Plummer-Vinson syndrome. The other name for this syndrome is Patterson-Brown-Kelly syndrome. Correct? With this, I finish off with this module of esophagus, students. Now let us move to the next module of stomach. And thank you so much, everyone, and all the best.